Once everyone's settled, we'll get started. Sorry about the delay, but we do now have a camera, so we'll be recorded and put on Cat TV at some point. I'm not sure when. So thank you all for coming. Thank you for coming on a Sunday. We apologize for it being delayed from our Saturday a week ago, 2 weeks ago. These weeks are running together. But I'm Rob Plunkett. I'm one of the two state senators. With Senator Bongartz, we're trying to get folks down from Montpelier to talk to us about the issues at hand. We've done that a couple of times, and now we're here again today, and we're going to be talking about healthcare. Cost, transparency, and access in general. And as Dr. Cunningham joked earlier, maybe by the end of this we'll all be banging our heads against the wall, but hopefully not. Hopefully there'll be a little bit of clarity. And just brief introductions on our panel. So Ginny Lyons is here. She is the state senator from Chittenden South, or is it Central? One of the
Southeast is good.
Okay, so Chittenden Southeast. There's a lot of Chittendens over on the other side of the channel. But we're very grateful for her to be down here in Bennington today. She has been a senator for some 25 years, and she chairs the Health and Welfare Committee in the Senate, and she is one of those in Montpelier that is really the key players who understands and knows where our healthcare legislation is going. And to my right is Kayla Davis from the Battenkill Valley Health Center, and further down we have Estevan Garcia from SVMC. Each one will be giving us a brief presentation, or perhaps not so brief, because Ginny, we have some time. It doesn't have to go quickly. And then after the presentations, we'll be taking questions from the microphone in the middle. So unless, Seth, you have anything more, we'll be ready to get going.
Yeah, only to really say how much we appreciate Senator Lyons making the effort to come down here. It's a bit of a haul. But when I mentioned it to her, she immediately said yes, because she cares so much about this issue and has invested so much of herself in it. And I'll also say that part of the impetus for this was my realization, especially last year, as I watched things come across the floor of the Senate, that we actually are doing some things to control the cost of health care and to hold down a little bit the rate of increase. And so I went, wow, there's really something going on, and I know there is this year as well. And neither Rob nor I are on the Health and Welfare Committee, so we don't know nearly as much as Jenny does, or anybody, our other two panelists. So we just wanted to do what we've done before, which is get somebody down here. This is such a critical topic. Healthcare is maybe the biggest issue in the end in Vermont right now. And there is a lot happening, so we wanted to give people the opportunity to get a sense of it. And I know that the other two panelists are doing their part as well, and so I think together we'll have something really interesting here. So off we go.
Thank you, Seth and Rob, both. You have two very terrific senators in Montpelier, and I've enjoyed getting to know them and working with them. I am Senator Ginny Lyons. I do chair Senate Health and Welfare. I also sit on the Appropriations Committee, so that gives me a very wide view of what's going on in the State House, but more importantly in the state. I have been working, I have worked professionally in the area of academics and in developing various healthcare programs and workforce and so on. So I bring my experiences to the Senate. Today's talk is going to be a little bit narrow for some of you and a little bit wonky, and I look for all of your questions at the end after we've had an opportunity to share to clarify anything that seems too confusing. Healthcare is an overwhelming challenge, not just to individuals, but to our economy as a whole. We know that. And it's a high priority that we begin to address it as a crisis, as we did last year. Slide. Thank you. What we see here is some of the the way we invest our healthcare dollars or pay for healthcare, most of which goes into hospitals. It's actually 38%, 30.8, and then including some of the other that's listed there. Our vision, started talking about a vision for healthcare and breaking our broken, not breaking, improving our broken system to pull together the pieces that are good and try to identify how we can build a continuity of care from acute care to chronic care, inclusive of our community-based services for mental health, substance use disorder, and others. So the goals that we've set for ourselves to reduce the high costs that we see that we'll talk about in hospitals and to move some of those expenditures into primary care and into community access so that we have a focus on prevention. I love my hospital, we all do, and we want our hospitals to survive. So when we look at the high cost of care and the healthcare system crisis, we do recognize high hospital costs, failing insurers and payers, Vermonters struggling to make ends meet, and a loss of workforce, all of which contribute to our failed system. There's not one aspect or one part of the system responsible for that failure. We're all in this together. And one of the things that I embedded into early legislation in 2022, that we have a collaborative approach in resolving the problem. So whenever we write a bill, we try to bring all the players in together. So here you can see the cost of hospitals exceeds costs of all the other things that we have in our lives. And as I said, we'd like to shift that, that graph, so we're putting more into primary care or into other parts of healthcare. Go ahead. As I mentioned earlier, the effect of increased costs in healthcare has a direct effect on our income, our jobs, and overall the local economy. And we're seeing that across the state. When we have folks come in from the Northeast Kingdom or from my area in Chittenden County, anywhere you go in the state, we're hearing tales of loss of workforce, loss of jobs, and so on. You can go ahead. One of the problems with cost right now in Vermont is how much we pay for our insurance plans. Our benchmark plans offered through the ACA, that some of you may know it as qualified health plans, those plans that are available to smaller and large businesses and individuals on the market. So look at the difference between Maine and Vermont. It's significant. It's significant across the country. In fact, we're one of the highest in the country, and that's a very sad tale when we think about our economic situation. So, and then we think about our payers, and Blue Cross and Blue Shield, for example, pays 33.5% more than any Blue Cross and Blue Shield plans in New England, and 42% higher than national programs. So we are very high, both for ourselves and the insurance premiums we pay for, and also our insurers. That's the sad story, and part of the sad story on the next slide shows the high premiums that we pay for the bronze plans, the plans that theoretically are most affordable. And if you evaluate those bronze plans, we find that there's exceptional out-of-pocket costs and high premium costs. So if we move along, and then what does that do to us as individuals? And I said it makes it difficult to make decisions about what you do in your life. We've heard this before, but this is a study from the Kaiser Family Foundation. And I will say the slides that I'm showing you, I can tell you where they're from, and they're easily accessed. And I'm shared my PowerPoint with Rob and Seth, and so you can look at that. But decisions to pay for health care, really, what do I do? You know, do I buy food? Do I pay all my rent? Do I put things on layaway? How do I live? And this is the trend we're seeing, not just in Vermont. And I will say that a lot of the things I talk about are not significant to our state. They're also significant to other parts of the country. We also know this problem where many of our hospitals, this is 2024-23 data, we don't have newer data, this is from the Green Mountain Care Board, and it demonstrates the dire straits that our hospitals are in. Even with a high cost of care and the high input into hospitals, some are suffering greatly. That's a problem that we also have to face. So beginning in 2018, I tried to write legislation putting in place financial sustainability plans for hospitals, asking them to put those together. There was some resistance, but after the pandemic and after we continue to see some of the challenges we face today, hospitals are now all in. I want to compliment hospitals, the Vermont Hospital Association that we have, and the folks that are in hospital leadership positions for being collaborative with the work that we are doing. Next slide. So what do? I will talk about just a few things that we've done, and then I'll try to stretch it out a little bit to some of the things that are coming this session, this year, to make broader improvements. One of the things that I discovered was that insurance and provider, insurance and hospital, insurance and primary care, private insurance contracts with those providers are what we call black boxes. So we don't know what's in them. So when the insurance company goes to, or the insurance companies or the hospitals go to their regulators, like the Green Mountain Care Board, and they say, we need this amount of money, the board only has what those providers or insurers say. They don't know what's in that little black box between the two. So in a couple sessions ago, I put a bill in to open the black box up and allow for the regulators to look at those contracts. What is surprising to me that at least one of our contractors did not know, our regulators did not know that those were not, that was happening. They didn't know what they didn't know. So it was a surprise then. Now there's a willingness to explore those relationships and those contracts between providers and payers. So that's one thing we've done. That opens up some transparency for us, and it's most important for the regulatory environment. We also put in place what's known as reference-based pricing. You all know exactly what that is. I know some of you do, but I'll say it's an alternate way of paying for care. It can be used in hospitals, and it can be used for FQHCs, community health centers, individual providers, and I'll talk about that in just a minute. But it's a new way of pricing, and it will save us a lot of dollars going forward. So I'll come back to talk about that one. In 2026, we're seeing a reduction in hospital budgets of 2.5%. That was through legislation that we've done. That will demonstrate a savings. I will show you those savings in a bit. We've also put in place a sharing of electronic health records to make accessibility for patients and providers easier. And then I think one of the most important things that we've been working on since 2022 is our health hospital transformation plan, our state action plan, looking at what are the gaps and the needs in each of our communities in each region of the state and bringing folks together. So what kind of services do we need to help the people who live around us? Hospitals are right now in the midst of a huge transformation process where they are looking at cost savings and efficiencies that are all going to feed into this plan. They're also looking at greater linkages with primary care. I know you're going to talk about that. We're looking at greater linkages with primary care, which will also build a system of prevention that will prevent the need for hospital acute care later on. And finally, primary care. We've embedded primary care into the statewide health plan, and we're looking at legislation this year for that. So we are trying to find solutions. We're looking at new pricing systems and how we pay for health care. That's very important. And so we'll go to the next slide, which is, there are different ways to pay for health care. One is you pay for every single little service you get, every lab you get. And so if you're paying fee-for-service, that means if you're a hospital and you need more money, you just demand that your providers have more services, more x-rays, more labs, more MRIs. That's one way of ensuring the sustainability. Is there anything wrong with that? No, there's no law against it. When I say some of these things, it may strike you as uncomfortable, but the reality is this is how our health care has been paid for. With reference-based pricing, which I'll talk about in just a minute, we can put a cap on some of the fee-for-service, and then we also, in our legislation, we've passed what's known as global budgets, so we put an overall umbrella on how much spend each hospital can have, and so within that, the hospital can decide where the money goes for the services that they pay, that they have. So there are different ways to look at paying for health care. That's what this is all about. The one thing that I think about consistently with this is alignment and aligning payment, so that when you go to one hospital of the same type, you're paying something very similar or the same as going to another hospital of the same type. When an insurance payer is paying an amount for a service, they're paying the same or similar, so that there's some continuity and we don't have to worry about what we're paying wherever we go. And again, I'm talking about Vermont. So then let's look at reference-based pricing briefly. As I said, fee-for-service is where you pay for one thing at a time. Reference-based pricing is where you pay, it's a benchmark, it's a standard, it's a comparative payment usually based on Medicare, could be something else. So it's usually based on Medicare. So Medicare is used as a standard, and then you pay, for example, some of our Blueprint primary care docs are paid at 110% of primary care, and in the hospital you can see a reference-based pricing 500%, or 1,500% I heard recently, or 5,000% I heard recently. So you can pay pay different amounts based on Medicare. What we're trying to do is to bring all of that into some kind of alignment, so that if we see that there's a service like colonoscopy that is used a lot, high utilization service, and we find out that the payment for that colonoscopy is over 500% of Medicare. That's high cost. And we know a high utilization, high cost service, paying a whole lot for a whole lot of these things, that brings a lot of money in, but it all takes a lot of money out of the pockets of the patient and the insurers. So somehow, to balance how much money does the hospital actually need to maintain its services, and how much can we afford to take out of our pockets, and how much can the insurance companies afford to pay. So you can see it's not a simple process. It's a huge balancing act. The Green Mountain Care Board is struggling with this right now. We've been talking with them in our committee about how to move forward a little bit better with reference-based pricing. So as we put reference-based pricing into our legislation, we see that with our 6 largest hospitals, we're realizing approximately $89 million. If you look at that $89 million and you say, oh, our educators and their staff have insurance, 60% of our educators in our school districts, 60% of the costs associated with their insurance goes to hospitals. So if you do that calculation, you figure out there's about $10 million savings with the reference-based pricing that we're suggesting. You don't have to memorize all of this. All I'm saying is there's a huge savings. It's $10 million just for those school budgets. So if we look at, if we were to have a global budget, then we'd have the amount within which you couldn't go above that as a hospital, but you could do all your reference-based pricing in here, and you could charge different fees for different services, and then the Green Mountain Care Board could begin to see that balance of hospital sustainability, patient ability to pay, and insurance solvency. That's the big story that we're talking about. I'll just show you the regulators who we do have in the state who are working on this with us. The Green Mountain Care Board that I've mentioned, they do hospital budgets. They'll do reference-based pricing. The Department of Financial Regulation looks at contract transparency. They're in charge of insurance companies. And the Agency of Human Services, which is building the Health State Action Plan and working with us on transformation. All three of these are in legislation, and we've asked all three of them to work collaboratively with us because it can't happen without that environment. So I brought an example down of reference-based pricing for school insurance payments that I mentioned earlier, and I'll go through what most of the payments were for hospital payments, average hospital payments for our school districts. In 2018, 276% of Medicare. 2022 went up to 316. 2023 to 326. The result of that is higher cost premiums. Higher cost premiums mean school districts have to pay more for health care. And believe me, we all hear about that every day, whether it's from our constituents or from the news. So if not done properly, reference-based pricing can demonstrate an increase in costs for health insurance, for hospitals, increased costs that become less affordable. So if we were to go, as I said earlier, to a 230% rate for our school insurance payments, we would see a savings of about $40 million for schools. Premiums would drop by about 10%. So these are all about, you have to do a model and you have to figure it out, but this is the latest data that I have. So I'm going to move on from that. I'm going to come back. I'll come back in a little bit. I'll go as quickly as I can because others need to speak. But just one other thing that we did last year. Is that an alarm? No. Okay.
It's in the firehouse. I think they're working on something downstairs. So, yeah.
Okay.
But we do have exits. There is a fire exit over there and over there.
So one of the things that we did do last year, and that is taken effect in January, is to put a cap on the cost for high-cost infusion prescription drugs. So folks who go into outpatient clinics or into hospitals for cancer treatment. Now, those drugs have been marked up exceedingly high. And so for me, it's kind of antithetical to have the cost of a drug trying to save someone's life when they can hardly pay for their cancer treatment overall, and then to raise the price of those infusion drugs. So what we put into statute was an average, putting the price on those infusion drugs at 120% of the average sales price, and do not ask about average sales price because the price of prescription drugs is archaic and Byzantine. But just all to say we can figure that out. The savings have been significant there, and that's only been for Vermont's larger hospitals. It hasn't affected the critical access, the smaller hospitals, the little ones like Grace Cottage or Gifford or Ascutney. I did that one. So I want to show you this slide. These are the school district savings, because I think it's very timely. You're going to school district meetings and town meetings this week. We all are. Teacher and staff health care is a big conversation. So if we look at what the Green Mountain Care Board orders did for this year, moving into 27, there's a potential savings there of between 10 and 50 million. I mentioned earlier part of that. The cost of infusion drugs, we did an analysis for VHI, the Vermont Education Health Insurance Program, and that analysis demonstrates a $12 million saving for educators and staff, which results in about a 3% off the premiums for school districts. The NEA informed me that they are, and VHI, their insurance organization, informed me that they are no longer going to be covering GLP, the Wegovy obesity drugs. They won't be covering those. That will be a $16 million savings. That's unfortunate for people who have it, but honestly, we can talk about when it might be a necessity and when it might not be a necessity. All of those conversations that primary care docs would have with their patients. But that's a $16 million savings. The total premium reduction for those things that we've just talked about is between 3% and 7%. It probably is as high as 10%. So will we see that this year? Will we see that in 27? It is in statute that we should see it in 27. The Green Mountain Care Board has come in recently and said they're having a hard time. They want me to put it off till 28 or 29, and I've refused to do that because I think this is a crisis, and they need to act with alacrity to do it, and they can do it. We've been talking about this a long time, so I could be wrong with this, but we talk, we sit together, and we chat about it. But some of these things will happen, and the reason that one of the things I think we probably should mention is this one. Am I going too long? Okay. So this came from a friend of mine at Dartmouth. You may know him, Esteban May, Elliot Fisher.
Yes.
And so we took that one slide of Maine and Vermont, and then we asked the question, what's going on in the little alligator mouth here? It reminds me of greenhouse gases back in. All right, what's going on here? What could happen to lower that? And for hospitals, and hospitals right now are working in transformation. They're looking at administrative efficiencies, efficiencies throughout the hospital work that I can't talk about, but you can talk about. They're looking at collaboration and sharing services. Up in the northeastern part of the state, hospitals are working together to share HR, to share purchasing, and they're doing it in a way that will not cause for criticisms of monopoly. So the New England Health Collaborative Network is what it's called, if you hear that one, up in the northern part of the state. So it's North Country Hospital, Copley, St. Johnsbury, and Gifford has recently moved into that. Gifford alone has saved many dollars with their leadership. So hospital transformation between 25 and 26, with all the work that hospitals are doing, we're seeing a reduction of costs, or what I call savings, of about $100 million. That's huge. It will be huge when it translates to reduced premiums, and that's what our goal is. We have to get it down to us and to the people who have private insurance. Not a lot of people, but it's sufficient. And then by 2030, there's a promise of $300 million additional savings going forward. So what we need to look at next is how can we manage those high-cost, high-utilization services using reference-based pricing? How can we set a standard for those things that now are out of hand and cost us so much? And I've asked the Green Mountain Care Board to begin looking at that. If they can't start anywhere else, that's a good place to begin. How am I asking them to do that? It's in legislation. I'm doing that this year. So in 2028, we'll have a full-blown action plan for services where folks in the community are linked together for a system of care between our community health centers, our primary care docs, our designated agencies, those who provide social services, and others, to build within that plan a continuity of care. All sounds easy, right? And that we're going to do it. We are committed to doing that. The Agency of Human Services receiving the Rural Health Transformation Grant is going to be using some of that money to demonstrate how that can happen. But that doesn't mean that we need to stop doing what we've been doing all along with transformation. So I just will briefly mention, and then I'll end, our next steps. We have a primary care bill that we're working on to, as I said before, to build the blueprint, our community health team program, and to establish that system of care that brings people in at an early time, what we call upstream, before you really get sick or have the symptoms, to prevent those symptoms and to provide early care so that later on you won't need to go to the hospital or your illness won't be as significant. So that's scary if you're a hospital, because that means now you don't get all these sick people. However, if we can balance that, and hospitals have a role to play in the prevention process, which I know they have done in the past, we'll make huge strides. So we want to keep people out of the emergency department. We want people with their primary care docs. We want people comfortable going to them, and we've heard that that is exactly what happens when you have a robust primary care program. I'll just show you this slide. I'm not going to talk about it, except I'll just say one thing. One of the things that I've always been concerned about is how we are restricted from any oversight of our employee, self-employed employer self-insurance. This federal government regulates that. That represents a huge number of people in our state, 200,000. What we can regulate is a little small group of about 85,000 people, and we can do a little bit of regulation by asking Medicaid to apply for to the federal government for some things we'd like to have happen. So overall, the state, the legislature, the regulators don't have they don't have a huge oversight. We can look at it and we can say, you know, if we had a bigger insurance pool where we could spread the risk out a little bit, we might be able to do a lot better in lowering costs. So in my bill this year, I forgot which one it's in. I've got a couple bills we're working on. In my bill, we're trying to expand the public pool. So bring together our state employees, bring together our educators, insurance pool, and potentially bring together our local cities and towns. If we could bring that together as a big insurance pool and have them access our health plans, everyone would be better off. So that's a dream of mine, but someday we'll move forward. We can go ahead and that's another way of looking at the same thing. We don't need to see that. And that's it. Okay, so thank you all. Oh yes, go back to that one. So one of the things that, I have a bumper sticker sitting on the corkboard in my committee room, and it says it's more complicated than that. So as soon as we start to pull this thread, another thread comes out. Something unravels. So it is more complicated than that, but what we have done through legislation is to begin to uncomplicate what healthcare is in the state and identify some places where each of us can work. And there are many people sitting in this room who probably have great ideas, and I get people bringing ideas into my committee and to me all the time. But then we start to pull that string and the sweater unravels. So we have to be careful because I don't know what I don't know. The regulators didn't know what they didn't know. And now we're moving ahead. We're trying to move ahead with alacrity, but we're trying to move ahead in a way that won't unravel the good in our system and have folks work together. So thank you.
Thank you, Ginny, and thank you, Kayla, for running the. And next up, Kayla Davis will present.
Hi, I'm Kayla Davis, the CEO of Battenkill Valley Health Center in Arlington. We are Bennington County's community health center. So Senator Lyons talked a little bit about what a community health center is, but I'm just going to talk about how the care that we provide is different than traditional primary care. So community health centers offer primary care, but it's a whole person model. So we try to focus on the mouth through our dental program and through the mind with our mental health program and psych program, and also provide primary care on the medical side. So we are reimbursed differently than general primary care. We are paid through what's called a prospective payment system, which is a predetermined rate based on the characteristics of the region, rather than a fee-for-service model, which is the being paid for every lab and every different part of the visit. We are designed to provide preventive care to those who are underserved, uninsured, and underinsured. So we provide care regardless of a person's ability to pay, and we offer a sliding fee discount to help with that. Our work is subsidized by federal funding through the Community Health Center Section 330 grant of the Public Health Service Act. And this funding is really the federal government's investment into each and every one of your communities. The Community Health Center movement was born in 1965 out of the civil rights movement as a bold experiment with 2 community health center sites opening. 60 years later, we're now the largest primary care network in the United States, providing care to about 52 million people annually. It's 1 in 7 Americans, or 1 in 3 in rural areas. That is inclusive of Vermont. We serve 1 in 3 Vermonters. The way we provide health care saves the system money overall. So while we deliver primary care to about 14% of the US population, we only account for about 1% of the total healthcare spend. How our care is different. So, as I said, we provide all of the services under one roof, and we focus on prevention and early intervention. Trying to keep people out of hospitals, ED departments, when it's avoidable. Because we provide care under one roof in one electronic health record, our providers collaborate really easily across departments. They can refer back and forth. They can see that one of their patients who has a dental abscess is receiving antibiotics and refer them over to the dental clinic to get that taken care of. So it really focuses on how to make the entire body healthy. Beyond traditional medicine, FQHCs also focus on something called social determinants of health. So we believe that a person cannot be their healthiest self if they're worried about things like food, shelter, and transportation. So part of our model includes employing population health managers, community health workers, registered dietitians, nurse case managers to assist with things like transportation, housing, language access, care coordination, and this all further improves health outcomes. While there's a significant cost savings to the healthcare system through this model, care, the quality of care that is provided is not, it remains extremely high, and this is because we are extremely heavily regulated by the federal government. We every year put together something called the Uniform Data Services Systems Report, which measures everything from who we see, where they come from, how frequently we see them, if they have a chronic condition, is that under control. This report is published for public review. We're really proud that the last 2 years, Battenkill has been in the top 10% for clinical quality in the nation. We are audited by every year. We submit that to the Federal Audit Clearinghouse. We apply for Federal Tort Claims Act, which is a free malpractice insurance, but that comes with extreme reporting and oversight, ensuring that the quality of care is really high. And then we have on-site visits every 3 to 4 years, and our regulators look at our policies and procedures and contracts and everything in between. So in Vermont, there are 11 community health centers, 93 care delivery sites, and there's a presence in all 14 counties. We serve 210,000 Vermonters, about 850,000 visits a year, and directly employ 1,700 people. And you can see to the left the focus on children, veterans, elderly, and those who might not otherwise have access to care. We're considered a safety net of healthcare. So we are Bennington County's Community Health Center, and we have purchased what used to be the Brown Cow Cafe, the Loose Cannon Cafe, with the hopes of being able to have a satellite in Bennington. Over 700 of our patients come to us in Arlington from Bennington, and it's very clear that a presence in this part of the county is needed. A lot of those residents are the patients who have the hardest time with transportation, and so being in town, being walking distance to many of the other services in the county is really important to us. We do need funding to make that dream happen, but we are committed to working to make it come alive. So Battenkill Valley sees about 4,000 patients. We perform about 13,000 visits per year. We have 54 employees. And you'll see on the right, our payer mix is about 28% Medicare, 22% Medicaid, and 14% uninsured, 36% commercial. So about half of our patients are on Medicare or Medicaid. We, beyond our walls, are really committed as a community health center to investing in the community. Food insecurity has been one of the biggest passion projects, I would say, of the management team, and newly looking into nutrition insecurity. So we have food shelves in both of our waiting rooms. We have fridges and freezers in both of our waiting rooms that have fresh meals from Grateful Hearts. Grateful Hearts is 100% volunteer-run organization that takes ready-to-expire food from farms, grocery stores, and prepares heart-healthy, low-sodium, diabetic-friendly meals. Those are open to anyone. It doesn't matter if you're nutrition insecure or food insecure, or if you're having surgery and just need to have a way to have healthy meals while you're recuperating. We also worked with the Vermont Food Bank to launch a project, an alternate to Veggie Van Go model, where we distribute bags of fresh produce once a month. Usually it's about 2,000 bags a year into the Arlington community for anyone who lives or works there. And then we're launching a nutrition insecurity grant through Bi-State Primary Care Association. And the goal of that is to study how access to medically tailored meals can affect someone with chronic conditions. And so it'll be a year-long process of having tailored meals for the specific diagnosis and quarterly monitoring the health improvements. In addition to that, we spend a lot of time in the community, in schools, in daycares, libraries, trying to help educate our youth on healthy habits. Oral health, because there's such a limited access in the region, our dentist had said, what is the best way to get oral hygiene under control in youth, and that's to provide toothbrushes and toothpaste. So in fiscal year 25, we put 3,500 toothbrushes into the community and about 3,000 tubes of toothpaste. We've also worked to try to incentivize or encourage daycares and schools to brush twice daily. We found that we were putting toothbrushes into the community and children were throwing their parents under the bus, that they were actually not using those tools at home. And so trying to have twice daily brushing in the school to ensure that the oral hygiene is, that work is happening. In addition to that, we have an amazing staff who volunteer their time to provide free community dinners. And then you'll see at the top, our population health manager has worked to create a walking group. It initially started for folks with hypertension diagnosis and has turned into an opportunity for people who want to make friends or just want to get outside for their mental health. And so it's kind of taken on a life of its own. So how do community health centers, how much do we save the health system annually? In 2023, we saved Medicaid $38.6 billion by keeping patients healthy and avoiding unnecessary costs. This study validates decades of research showing the cost savings of community health centers to the Medicaid population. In areas with greater increases in federal funding for the community health center program, patients with Medicaid are less likely to delay seeking care due to cost and are more likely to have a usual source of primary care and are less likely to source their care from emergency departments. Another study showed that pediatric patients who received their primary care from a community health center had 20% more primary care visits and 17% fewer hospitalizations compared to non-community health center patients. Given that we are, and I'm looking in the crowd at many of our board members, we are a patient majority community governed board. The structure ensures that decisions are made by people using the services and living in the community. We're nonprofit, mission driven, with no ability for any shareholder extraction. And our reimbursement models are aligned with value-based care models. Every $1 invested in primary care returns $13 in downstream healthcare savings. So key takeaways. The community health center model addresses root drivers of cost. We emphasize prevention, early intervention, and chronic disease management. We serve all regardless of ability to pay. We address social determinants of health, align services and growth with community need, and are a scalable model for system sustainability. That is my presentation.
Okay, great. Thank you, Kayla. Esteban, take it away.
Great. I do want to leave time for questions, so I'll spend just about 5 minutes. I don't have slides, so you can look up this way. So I'm Esteban Garcia. I'm the new CEO and president of Southwestern Vermont Medical Center. I've been here 6 weeks, but didn't come from that far away. I'm a pediatric emergency medicine physician, and I've been a healthcare regulator. I was the chief medical officer for the Massachusetts Department of Public Health for a couple of years during the pandemic, and I think that really really did prepare me to face the challenges that we are facing, that our community is facing, and that healthcare is facing in Vermont. Healthcare is too expensive in this state, and actually in most states, if not all states. And so we are part of the problem, but we're also part of the solution. We're not the only problem in healthcare. Hospitals are not the only problem. I appreciate the senator saying that we came into this together. We want to be at the table to help address some of these issues. So one of the things that I want to highlight is that over the last couple of years, what we've done to reduce expenses at the hospital pretty significantly, and I know I've only been here for 6 weeks, but this work started well before under our board. Two of our board members are here, but also and under Tom D as well, and the work that he and his team did to help make sure that we were able to start addressing some of these issues. So the hospital system started to address these issues across Vermont. $230 million in operational expenses were reduced over the last year. SVMC's share of that was about $12 million. $7 million of that was from Act 55 and $5 million as well from other expense caps. So the way we did that is we partnered and have partnered with Dartmouth Health. So we were able to start addressing some of those really expensive things we had to do individually as a small hospital, right? We were able to address back office functions. We were able to look at things like our insurance and lots of other expenses, purchasing agreements, things that we were able to reduce costs. And that's been, I think, really important for us. When you compare SVMC to other hospitals in the region, right, Albany Med is not far away. I think it's too far for an emergency. That's one of the reasons we're here, but it's not that far away. Much more expensive healthcare than at SVMC. And if you look down into Massachusetts, again, not that far away, healthcare is more expensive at those hospitals than it is at SVMC. So I think it's important to understand that as well. We want to keep Vermonters in Vermont, right? If we have to send you to a hospital for a higher level of care, we will do that. It's in your best interest. But for everything we can manage, we want to keep you here so that we can take care of you, and it is the least expensive health care you can get compared to the hospitals that are in the area around us. So we think that's also important. So when you think about at 2 a.m., 3 a.m., who's open, right? Southwestern Vermont Medical Center is open and is waiting for you if you have an emergency and you need to come see us. That's one of the reasons that our healthcare is expensive, that we have higher operating fees than a freestanding X-ray place you can get your mammogram, or you can get X-rays, or you can have your labs done, because those are open from maybe 7 a.m. to 5, maybe 7 to 7, right? But at Southwestern Vermont Medical Center, what I have for you overnight is an emergency department that's available. I also have an operating room that's ready and available if you need surgery. We do surgeries at 2 a.m. when they have to happen, right? And some people can't wait. I have an inpatient unit that has a provider, a physician, rounding and admitting patients from the ER to that unit overnight. I have pharmacists that are available to fill prescriptions that have to happen overnight for our patients. We have nurses available 24/7, nurses available overnight, I think, and labor and delivery, right? So we are where people come to deliver, and I think that's really important for us as well. So we want to be at the table. We want to help reduce prices. We've been doing that. But one of the things that I think is important to understand is that it is precarious, right? There's only so much I can cut from the system. And partnering with the Green Mountain Care Board, I think we've done a great job. VOS, the Hospital Association, there's 14 hospitals there. The majority are critical access hospitals. We are not a critical access hospital. We're a PPS hospital. And so it's important to understand that as well, that we get paid differently. We don't have some of the subsidies that you see at critical access hospitals. And what we're hearing is that the draft guidance from the Green Mountain Care Board is that we cannot increase our expenses at all for next year. Even if we had money to spend, I feel like, I've got money to spend. Even if we had money to spend, we can't do that because they've told us that we have to have a zero expense increase for next year. That's going to be difficult, right? The electricity company told me that we can expect 7.5% rate increase next year. So I can't increase expenses, but I have to be able to pay for electricity to keep the doors open, the operating room running as well. And just I'll end by saying that when you think about what SVMC does, so we see 1,000 patients a day in our ambulatory clinics. That includes primary care. Not all hospitals hospitals do primary care because you lose money at primary care, right? We do primary care. We want to grow primary care. We will hopefully be able to open up a primary care residency in this community so that we can then start growing our own, bringing doctors into this community because it's really important to bring them. Rural healthcare is very difficult to attract, so that's something that we're doing. But so 900, we have express care, a way that's less expensive than going and waiting to get into the emergency department. Also, hopefully quicker. Express care sees about 80 to 100 patients a day, and our emergency department sees between 60 and 80 patients a day. Now, some of those emergency department patients are better off in our ambulatory care, our express care, or at Battenkill, right? And so we really want to make sure that we are only seeing patients in the emergency department that need to be there. And, we admit about 13% of patients, which is the national average. We're not admitting more patients that need to come into the hospital, and we want to keep you there as short as we can so that we can then ready for the next patients to come in. So I'm happy to answer questions, as are my two colleagues here, so we'll throw it open at that point. Great, thank you.
Thank you, Esteban. And so questions. We do have a microphone in the middle. It's corded, so I think the way we can do it is just as is happening now. Anyone has a question, come up to the microphone. If anyone has trouble going up to the microphone, raise your hand and I'll make sure that your question is asked, or you could just holler it out and we'll make sure it's recorded.
Thank you.
And give your name, too.
Yeah, I'm Jim Miranda. I live in East Dorset, which is northern part of Bennington County. I apologize. I have a question about one of Senator's slides. Is it possible to bring that back up? It was Economics 101. If you can, I'd really appreciate it. In the meantime, thank you.
The one about the economy?
That was part of it, but I really wanted to ask about the healthcare premium. So thank you all very much for being here, especially Senator Lyons, because it is such a long journey. I've asked for the sun to come out this afternoon so you have a dry and safe journey home. It was towards the end, actually.
Slide 4.
My perspective is from a self-employed individual. My wife and I are both self-employed, so I'm really focused on healthcare premiums. We have 3 children, so we're not going to go without healthcare. But I hear so much from Montpelier and Seth. Mr. Bongartz, I'm not going to look at you, but on the education issue, property taxes, it's a very important issue. So much of what I hear coming out of Montpelier focuses on that issue. I'm so glad that you're focusing on the healthcare issue. My healthcare tax, which is what my premiums are to me, is a healthcare tax, are 5 to 6 times what my property taxes are. I'll repeat that. My healthcare premiums, my healthcare taxes are 5 to 6 times what my property taxes are. So while I appreciate what's happening in the property tax realm, this is much more important fiscally to me. So this graph, I'm familiar with these numbers. Can anybody, I have 2 questions and I'll sit down. Can anybody talk about what happened around 2018, 2019 to start bending that curve for Vermont? Now, it was before COVID, and certainly if the healthcare premiums started rising in 2018, 2019, that would mean it was something that happened in the years prior to that. If anybody can address that so I can understand why the curve started bending then, I would appreciate it. My second question is going to be a little bit surprising, but if we need to expand the insurance pool, why does a small state in the country need to run its own healthcare program? New Hampshire doesn't. They're on the federal exchange. So it's kind of a big question, but why can't we do that? Thank you very much. I'm going to sit
2
down.
really good questions. So to answer your question, the first question, why does it all of a sudden escalate? I think the pandemic does have an effect there. I've been asked, it's a conundrum, I've been asking the same question, and the person that I will reach out and ask again, I do have data on that. I did not bring that with me, so I can't give you a great answer on it. But we did receive a lot of federal dollars, and it was used, they were used by our insurers and others. I can't answer, but I think it's partially due to the amount of money that went into our insurers. Don't know. I think part of it is the economic downturn that we had during COVID. So I will find that answer and send it by way of my two colleagues. But that is a conundrum. What really is going up there aren't your premiums. It's how much your insurance company has to pay for the care. So what's really going up there is the cost of care, the hospital cost, the provider cost. Some of it's going into the insurance companies, and we've asked insurance companies to do similarly to what hospitals are doing in terms of administrative costs. So everybody, I guess everybody's guilty, except for those of us who have had to pay that increased amount of money. I guess we could be guilty too, but I'm not sure how yet. That's an awful thing to say, guilt, but this is just what's happened, and it's happened across the country. You can see, but it's happened worse in Vermont. We have the highest cost hospital in the country. My hospital is the highest cost academic medical center in the country. Why is that? I don't know. When I ask them why they have high costs for their administrators, it's because they have to be competitive with the rest of the country, or higher. So we'll see what we can do with that one. Thank you. Your other question was, how come we can't go with a federal program? That's a question for our administration. We are locked into Medicaid, Medicare. We have one of the most robust and one of the best Medicaid programs in the country, if not the best, because we have some latitude in what we cover and how it's covered. I would say if Medicaid could administer more lives and more programs, we would be better off. The hitch there is how much it costs. But your question does lead me to another comment, which is, I am asking our executive branch to look into a joint relationship with other states for health care. So that could happen. It's not something that happens right away. There are a lot of barriers to that, but so not a very useful answer, not a direct answer, but we can get more information if you'd like.
Did you want to say something to add?
Come on up, Bill.
My name's Bill Fisk. I'm a resident of Shasberry. My questions are mostly related to global view of healthcare. Why does the United States healthcare cost about 150% of what it does in other industrialized parts of the world? For example, Switzerland, where I think our cost is about $15,000 a year. Swiss is about $10,000 a year, roughly. Why is that? And why is it that our clinical outcomes aren't at least as good as the Swiss? We have poor clinical outcomes relative to other industrialized nations. So that's the first part of my question. I guess that's all part of the driver. What does healthcare cost and why?
I mean, well, we don't have universal coverage, right? And so I think that is certainly one of the challenges. Our population is very diverse. We're nothing like the Swiss and other, we have a really diverse population. The populations and their coverage is also varies by state. So if you look at the United States, there are a lot of states that don't cover and don't have as general Medicaid as coverage as we have here. So I think that is a concern. Because to Senator Lyons' point, not having primary care results in long-term, more expensive care, right? And so people come to the emergency department. So I'm a pediatric emergency medicine doc. I see kids in the emergency department. About 80 to 90% of what I see in the emergency department could be seen in a clinic, in an office, if they had access to that. And many don't, not necessarily in Vermont, but just across the United States. So I think that's one of those issues. I think luckily for us in Bennington and in Vermont, we actually have a quite good quality, but when you look at it across the United States, it does vary quite a bit. So, but I think part of it is just everyone's not covered, and that means that some people are much more expensive and they're not getting the care they need early on, would be my understanding.
So if we had universal care or universal payer system, do you think we'd be better off in terms of cost?
Well, I think that's one of the suggestions, or one of the solutions that has come up. Again, we have to look at it, but that certainly is a difference. I think the question was the difference. That is a difference, right? They have universal, we do not, and so I think there is. When I see, I can't even look at medical records when I work clinically sometimes to know. Wouldn't it be nice not to have to do 3 or 4 different tests on a patient? I don't do those tests because the hospital gets paid when I'm seeing them. I do them because I need them. But what if they were done earlier in the day and, at an office, and I could actually see what was done? And we don't even have that necessarily across the United States, not in Vermont necessarily. But so that's an issue, I think. But yeah.
Let me see.
Just a quick comment on, we did try to move to single payer about 10 years ago,
Yep.
a little bit more. And the actuarial analysis that came back from Dr. Shao at Harvard indicated that we'd have exceedingly high payroll taxes, and there was a significant concern about that. We don't have a large population in the state, and as I indicated earlier, we don't regulate a big chunk of the population, which are the employer self-insured. So it's about 200,000 to 300,000 people. So to move to Finland, I'm saying we aren't moving to Finland, but if we're going to try to emulate Finland, it will be costly. And it will take a chunk out of the paycheck if we were going to do that. And then your question about value-based assessment, we are, in the bills that I'm looking at next, and I've been looking at for a long time, will build on some of the quality data analysis that will allow for hospitals and clinics to know what value-based care, which you already work with, what the value is for a specific type of treatment protocol, clinical protocol, so that we can begin to spread what FQHCs are doing further into a greater population. There's a lot going on.
You just right into my next question, and I'll go away in a minute. Are the Medicare reimbursement rates fair as they're set? I get a bill, I've had surgery. The bill's hypothetically $30,000. I see the provider in the hospital getting $5,000 or $6,000. So are those rates set fairly?
So I think there's, it's really complicated because of the way it's spread over all the patients, right? So you've got Medicare patients, we've got Medicaid patients. This state has a high Medicaid rate, and so and the reimbursement for Medicaid is lower, and so trying to figure out how do we spread that out over all our patients, and then you have your insured patients. So I think it's certainly that the rates are fair, but it is difficult to figure out how you normalize that across patients and then the charity care, right? So if you come into the emergency department, we will see you. We don't ask for your insurance before we see you. That's not legal, right? You actually have to come in and be seen and be evaluated. It's called EMTALA. We have that rule, and so we will take care of patients regardless of their ability to pay, and then we have a large charity care pool. But yeah, these are difficult depending on what surgery you're talking about. But I think the rates are certainly, the Medicare rates are better than the Medicaid rates for what it costs us to take care of a patient. So.
Medicare rates are better than Medicaid rates.
Absolutely.
I understand that.
Yeah.
And there's also the politics in setting those rates,
right.
I assume.
Yeah.
But the reality is, if those rates are representative, why are we using a multiple of 200% of the
right.
Medicare rate?
Right.
What does that imply?
Right.
If the Medicaid rates are right, why shouldn't we be getting the Medicare rates? Right. I'm not here to debate. I don't know the answers to your questions, okay?
Yeah, it's that, what was that sticker? What was your bumper sticker?
It's more complicated than that. Yeah, so if the state wants to raise Medicaid rates, and I've just asked our administration, how much money would it cost to raise Medicaid rates for primary care? I'll get that data back for all of our primary care docs. How much would that be, to raise it 1%, something? even if it looks good to us, and it would cost the state $2 million or $5 million, we have to ask the federal government for permission to do that. So it's not like we regulate Medicaid. We don't do that. But we can look to see what's needed to make our system sustainable and then ask to have it done. Makes it hard.
Well, thank you. I appreciate the opportunity to be here and listen to these questions. Thank the two senators and the third senator for the information, the other people as well. Thank you very much.
Thanks, Bill.
Thanks, Bill.
Hi, my name is Nora Dyer Murphy. I'm a student at Bennington College. Thank you so much for making this forum. I'm wondering, Senator Lyons, when you brought up school district savings, right? You mentioned that like $10 to $50 million are going to be saved in like educator healthcare and teacher and staff healthcare savings. And I'm wondering, what is that looking like from the educator's perspective? Like, is their insurance going to be covered less? Like, are they going to have to pay more out of pocket? Like, what's that going to be looking like for them? Thank you.
No, so the question you're asking is two different questions. So
Yeah.
So the savings would come out of the premiums.
Okay.
Yeah. So and it would be ongoing. So
Okay.
if it's $40 million, it's every year, continuous, and then the out-of-pocket costs are things that would be a part of the health plan that they have. So that wouldn't change unless it were a negotiated change. Well, it could be a change for services.
Thank you. I appreciate it.
Yeah, okay.
Hi, my name is Tom.
But let me say one little tiny thing about that. My goal is that primary care will not have out-of-pocket or increased out-of-pocket costs be zero, and that you'd have visits to your primary care docs at least 3 times a year without payment. Well, that's part of it.
Thank you so much.
Yeah.
My name is Tom Blakely. I'd like to, here in Bennington, I'd like to start with a little bit of feedback about the two things that I've heard, and one of them I had heard before, that got me most excited. And one of them is the primary care residency, and I think that's a great idea, and I really look forward to that becoming reality. The other is the community health center, which I really wasn't aware of, and I think you're doing great things, and I'd like to talk to you about, what you need for support and anything we can do to help.
Thank you.
I spent most of my professional life in IT, and so while I'm happy to see the electronic health records initiative ongoing, and I actually was a little bit involved in that as a consultant at some point. I'd like to ask what other initiatives are using technology to help bring your costs down and improve patient care. And the two things that I'm particularly interested in are telehealth and using AI to do screening or triage, or even, the kind of things you do when you see your primary care doctor, to get all that out of the way so that they have the information and can deal with it initially.
Sure. I'm happy to. So we are, we started using AI. Certainly, we have there's an ambient AI product that when you're in the office, we ask permission to use it, and it is able to record, and fill out your medical record. So that, because one of the most costly things is to have a provider spending time at the end of the day, or into their evening, working on charts and working on the medical record. And if that can happen at the same time that you're seeing a patient, then that's a real win. We're doing that. That's one thing that we've initiated. Now, our medical record, we have multiple medical records and multiple operating systems within SVMC, and it is one of our biggest challenges, right? So to get a patient registered for a study, because of the way we've patched together different systems, can take half an hour of one person working to get, to order your mammogram, right? And I mean, it's ridiculous. And we're working on it. We're trying to fix it. It will be much better when we move to Epic. And so Epic is our system. Dartmouth Health is on Epic. It's a national electronic medical record. We need to move to that. We're slated for 28. It's expensive, but it's something that we know we have to do because our other systems have fallen behind. So we are using AI even in our current system, and it will then move to some of our future Epic and future systems. So and we also use it for kind of predictive analytics, right? So if I'm in the hospital and you put all my information in and it says I have a 15% chance of having a heart attack, then that is something that my provider needs to know based on my complaints and other things. And so there are lots of ways to use technology. And I'll touch on the telehealth services. So recruiting to a rural area like Bennington is a real challenge, right? You have to have a reason to come here. You have to have gone to college here. You have to have family here. I think, I was none of those, and I think it's a great community, but it's a lot harder to bring in folks from the outside. So there are some services I just can't provide, right? So specialized cancer services. We have a great cancer center that does general cancer care, and lots of philanthropic investment in that cancer center. We're breaking ground on a new cancer center, $30 million, that we're raising the majority of that through philanthropic funds. But I will never get the specialists from Dartmouth Health to be here, but we can do telecare, and we do it today, right? So benign hematology, so it's blood disorders. Right now, I don't have a specialist here. It would be too costly to get one here, but we have a specialist from DH that's doing telecare for us here. So that's just one example of telecare. We do tele-ICU. Very expensive to have ICU providers on staff when maybe I need them, for every 2 or 3 patients potentially. So I can get tele-ICU, and I have a contract with DH, and they provide my tele-ICU services for us. It's not free, but it's much less expensive to do that. So teleservices are fantastic, but yeah.
Yeah. As AI sort of matures, we're using it more and more, and we're really excited about the administrative burden that it can reduce. So our providers receive 50 to 80 documents per day from referrals that come through. Right now, we can have many of those documents be scrubbed and summarized by AI so that the provider gets kind of like a electronic sticky note that says, the mammogram was clean, and then that can just go right to the triage team, for example, to call the patient back. There's some limitations with if you receive an image, like a fax of a document, it's not quite smart enough yet to handle that. And then eventually we'll be able to, and we're kind of testing it right now, have it auto file in the correct medical record all of the supporting documents that we receive from specialists, which right now just takes a full-time person in our little practice to just scan through, assign, and file. We use telehealth regularly in our behavioral health department. One of our psych nurse practitioners, she works 3 days a week from home. And that really changes people's ability to be compliant with their care. They can have their 30-minute visit from their car at work. They don't have to drive to Arlington. Same thing with behavioral health. If it's a barrier to come in and be seen, we can change it to telehealth. Right now, I would say, I don't know how much of a reduction in care, the cost of care it is for primary care setting, but certainly when providers can do provider-to-provider consultation and stuff like that, it's being used. But we're excited to see where it can go. I don't think it'll ever, and I hope it never takes place of a doctor, because I think that's really dangerous, or could be dangerous. But yeah, certainly using it to reduce administrative burden, which again increases the cost of care, because we're employing all of these people to do stuff that hopefully AI can help with.
That's great. I just have one last comment. I'm within easy walking distance of Southern Vermont. I would love to have my primary care there, but they're not taking patients.
We have a couple of sites that are taking, but you're right, at VMC, we're still working on it. We actually have a very nice practice site that's ready to go. I've got to recruit for it. So, as the CEO, one of my primary responsibilities is recruitment, and it's a challenge, but you're right. Right now we have new patients at Northshire, Pownall, Twin Rivers, and then pediatrics is taking patients, but the internal medicine site there is closed at this point, but thank you.
But you're not.
I'll work on it.
I'll just say, you're not alone.
Right. I know that.
Yeah, it's across the state. And so we're putting in workforce dollars that would provide for bringing primary care. On Thursday, I heard from Josh, who runs the FQHC up in Island Pond, and they absolutely need a primary care doc. They don't have one. It's the same story across the state. I will say something about telehealth. We've passed a significant number of laws that elevate telehealth and make it possible. I am very concerned about what the federal government is doing with respect to the older population, Medicare population, and limiting telehealth there. Our hospitals are terrific at providing telehealth care and also communication physician to physician. And then finally, just a quick comment on EHR. The critical thing, and you're talking about Epic, I'm glad to hear it's Epic, it's also Epic at UVM, but having interoperability between hospitals and clinics is not happening right now, and it is expensive. And then finally on AI, I agree, we need to be careful that our insurers aren't using it for all of our prior authorization decisions and decisions about care. So everywhere you go, there are concerns, whether it's patient confidentiality or interoperability, it's all fit together.
Yeah, I want to make it clear, I was not advocating for just jumping headlong into AI. There are some issues that need to be addressed. Thank you very much for your response.
Thank you.
So we're at 12:30. We got two more people, so we'll hear from two more.
My name's Walt Klinger. I live in Pownell. I'm retired. I live on retirement, and as you may be aware, it got bumped up by 2.8% last year, so every penny in my budget has to count. I see healthcare providers to get what I need in coverage in Massachusetts, New York, and Vermont, and that may be expanding into New Hampshire in the near future. But I recently saw my cardiologist, and he said you have to have a procedure, and we need to put you on a blood thinner for a month before and a month after. And they gave me the script, and when I checked with a pharmacy, it was $400 a month, the cheapest I could find. So I called the cardiologist and said, I can't afford this. And they said, oh, well, let us hook you up with a mail order we have with our partners up at Dartmouth. So I talked to those guys. Guess what? It's $70 a month mailed to me from up there, and it's $70 a month. I'm sure Dartmouth is making a piece of money, and I'm sure that the folks that make the drug are still making money. So, this is amazing to me how the public gets ripped off by the drug companies, and it's just absolutely outrageous. When I was working for the railroad 20 years ago, I had insurance through a union plan at the railroad. That plan for family, covered family completely, $220 a month is what it cost me, and we paid $5 or $10 per script copays when we got our medications. Now, my question to you is, if 20,000 people at Amtrak could have that insurance, why can't everybody have that insurance in America? And when my wife was treated for ovarian cancer at Brigham and Women's Hospital, Dana-Farber, that treatment didn't cost me anything except my monthly payments. So all I had to do was get her to Boston for her treatment and get her home again. That was it. And it was, I'm sure it was hundreds of thousands of dollars, and it was paid for 100% by my union insurance through Amtrak.
You had a good insurance coverage, and it was negotiated by your company with the insurance company. I don't know how long ago it was, but that's part of the negotiations that I was talking about early on, where providers and insurers, in this case, the employer and the insurer, discuss what can you provide for us at this cost. And so because it sounds like it's a large organization with many people in that risk pool, that brought the cost down for that employer. And it's all through that single organization and negotiation with the insurer. That's not something that we can regulate at all, which is sad. But if we could put everybody into your insurance program, we'd solve a big problem.
And I would just say that on the medication, I think that with the Dartmouth plan is probably the 340B savings that the hospital is able to utilize, and so that is a program specifically that allows the costs of the medications to be less. You have to qualify for that. It's usually a certain number of Medicaid days that the organization takes care of. It's another way to kind of level that, what it costs for taking care of Medicaid patients, and so a lot of the systems have that 340B. We are part of that system as well, and so but we don't do the mail order that the system does. So I'm glad they were able to find that for you. But yeah.
Well, thank you all for having this dialogue and wrestling with the healthcare octopus every day.
You got it.
Hi, I'm Dr. Michael Welter. I'm a retired family practitioner from Arlington. So I have two comments, both of which have been touched on. But as we saw, primary care saves a lot of money. Why or can we have a more robust loan forgiveness program to encourage medical students to come into family practice, and particularly in Vermont? They usually have $200,000 or more of debt, and we are competing with big cities, community, suburban areas, et cetera. I think the state could do more for this.
Boy, that's one of my pet projects. The governor recently introduced his budget and eliminated all funds for AHEC, the Area Health Education Group, which does have within it a loan forgiveness, tuition repayment program, set of programs based on what we need across the state. I'm on appropriations, and I'm looking to put money back into AHEC during the budget process. It couldn't be more critical. We've also passed a number of workforce bills that relate not simply to physicians, but also to nurses, mental health counselors, and others. So you've asked an excellent question, because if we don't provide an incentive, and that incentive being, we'll help you pay off that huge debt. I've already been through that with my husband. He's a retired physician. And it's a lot of money, and the more help you can get, the better off you are. And the more apt we are to have folks sign up to work at the local community health center or at the hospital.
If we can bring them into the residency program,
Yeah,
and incentivize them to stay.
I will say that primary care in rural communities is some of the hardest care. And it's harder than primary care in an urban center, because in an urban center, you can refer every time, go see the GI doc, go see the rheumatologist, go see the cardiologist, go, and in rural centers, our primary care docs really do, at the health center do so much, and they want to keep the patients local, and they want to keep them from the expensive care that we talk about. So yeah, absolutely. Anything we can do, we're in favor of any of that we can do to be supportive. So thank you, and thank you for everything you did here in the community.
And I think those family practitioner residencies are trying to beef up the number of people coming.
Yes.
So I think we have to find a better way to incentivize them to come here.
Thank you.
The other comment I had is that we're fighting demographics, an aging population that's costing more and more money. Isn't there some way to regionalize with New Hampshire and Maine just to increase the base pool? maybe they don't want us because our expenses are too high, but on the other hand, it just creates a much larger pool population.
Yeah, we're equal with Maine in the aging population area. We do run into interstate commerce issues, but expanding the pool is something that we've asked our executive branch to look into across state lines. It would be great to have a consortium of some kind. And for the first time, I think insurance companies are willing to talk about this type of arrangement and collaboration. I had them into my committee last week, and we had such a good conversation. And it's just, the devil is definitely in the details, and talk about complexity, it's huge when you make that suggestion, but it's a really good suggestion.
Thank you.
Thank you.
Okay, we'll do one more.
Come on up, Leon.
Yes, Leon Johnson from North Bennington, and I got most of the questions already asked and on the books and so forth, so I'm down to some of the real ones that we've not really spoke about. And we talked about health care, but then I'm remembering back quite a ways back where a lot of the type of opportunities to provide and check an individual was involving multiple people. As we got into new technology and started to be able to put on certain leads and do other kind of things and look into the body, we started to buy a lot of equipment and drive up. And I don't know that that's really the driver of what we got when we saw here on the board, what the health care looked like, because we using all the automatic equipment. And how many years does that equipment last, and how many hundreds of thousands of dollars that we have to pay to put a particular unit up at the hospital or over here and not share it somewhere else that may be affecting our costs that we can do something about. So I wanted to bring that out. The other thing is, why is it that some insurance companies are able to refuse payment or refuse payment for a treatment, or say that treatment is not okay, and the individual that need it is either paying it out of their pocket if they can afford it, or they just fall to the mercy of the hospital when it get bad enough that they have to come to the emergency room. And then you said, well, something that the primary care could have got earlier or got approved was only cents involved. Now I got to have all these major treatments to this particular individual or people out here when I could have had it under control some time ago in their life. Mm-hmm. And I see you covered all of the health things out here in terms of food and so forth. That's those are big things that I see that we push a lot of in Vermont in terms of healthy foods. Right farm to house is one of the big things, and we talk about a lot of processed foods, and you start to talk about the number of people in certain areas and what they can afford to have. They eat the processed foods is full of a lot of the sugars and salts and so forth along that line, because that's what they can get. We don't farm like we used to and provide a lot of the things. So I don't want those to be left off, because everybody is taking everything else that we need to talk to, but I wanted to raise those.
I would love to just respond that I think what you're talking about is prior authorizations, and that is such a pain point, a delay in care, a rise in the cost of care. I think that we need to trust that our primary care providers are not going to be asking for unnecessary tests. And you're right, we have a full-time referral and prior authorization specialist that their whole job is basically waiting on the phone, trying to get things authorized with insurance companies, and it's a problem. And if there is enough delay, they may end up going to the hospital and accessing it that way. And I think that that's something that's been brought to the state.
We did it, yeah. We had it for a year trial. we sort of said no prior authorization for primary care. That is going out. It's been going on for a year. That law ends, and we're going to try to put it back in. I'm going to put it back in. I don't know what anybody else will do, because it is such a barrier to appropriate care, and primary care docs are not trying to scarf the system. They're trying to help the patient. We've learned that more and more and more. So good comment on that one. And the other one on buying all this fancy equipment that you were talking about, we do have what's known as a certificate of need process. Do you need to have that new piece of equipment? How much does it cost? So at the Green Mountain Care Board, there's like a little threshold. If it goes above this amount and you're going to buy it, we have to review it and see, do you actually need it? Because there might be one in the hospital next door or at the community health center. So that certificate of need process is actually an important process to stop the concern that you have about too much too quick. But it also helps get things in place that we do need. I'll make one final comment on the blueprint for health. With the blueprint practices with our community health teams, and we're trying to reinforce that at the primary care level. I helped start that when I first went into the Senate. It's an amazing program. Your work is so good and reflects that.
And we have blueprint clinicians at our practice who are able to provide services at no cost to them. We have a therapist, we have a registered dietitian, a community health worker, and so that program is amazing.
It is. It's great. And we're getting rid of red dye and other bad chemicals in foods in schools, I hope.
So,
Thank you.
thank you, everybody, for coming. And I should have introduced Mary Morrissey and Mike Nigro at the beginning, representatives who made the effort to come out on a Sunday, along with all of you. And thanks. This was actually really good. This was, I got a lot out of this. So I hope everybody else did too. So thanks to our panelists. Thanks to everybody for coming. See you next time.
Thank you.